Hello, are my slides visible?
Yes, ma'am.
Okay, thank you. And are they moving now?
Yes, ma'am.
They are moving, no? It's not my first slide.
No, challenges in India.
Okay,
Is
thank you.
moving.
Thank you for the information.
Yes, Dr. Malini, your slides are visible. Just try moving them.
Yeah, thank you so much for the information. Yeah.
Yeah,
Are these
great.
moving? Yeah, thank you.
So, good evening, everybody. Welcome to this class on Candida, which Dr. Malini, professor at VMMC and Safdarjung Hospital, has kindly agreed to take it for you. So, if you have any questions at the end of the session, please unmute yourself and ask Malini ma'am, or you can type them in the chat box. So, I think we can all see Dr. Malini's screen. I think Dr. Malini, I think we are good to begin. About almost
Yes,
50%
thank you,
people
Dr.
have joined,
Sonal.
and you're
Yeah.
also being streamed live on YouTube.
Okay. Thank you so much, Dr. Sonal. And good evening, everyone. At the outset, I would like to thank IAMM, Indian Association of Medical Microbiologists, Dr. Sonal Saxena and Dr. Manitesh Nagmoti for giving me this very pertinent topic. As we all know that Candida species cause the most common fungal infection, that is candidiasis, whether it's the superficial or the invasive, both the Candida species is most common. And especially with ECMM and the ISHAM, that is the international organization, releasing the candidiasis guidelines in February 2025 only. So this becomes very pertinent topic. What's the new change in species or the identification or the antifungal resistance? These guidelines cover all that. And so you can post the questions as Dr. Sonal has advised in the chat box or at the end of the session. Okay, so Candida species identification and antifungal resistance. If you look at, slides are not moving. The slides are not moving. Slides
Dr.
are not
Malini,
moving.
just change the screen set and then do it again. Just
Slides are
close
not
the
moving.
PPT and share it again. वो hang हो गई होगी.
Okay, I'll just, I think this thing it, yeah. I'll just stop the share and yeah. Yeah, so now my slides are moving. Yeah.
Yes.
So yeah, fungi, as you see, they are masters in survival. They have survived the 1 billion years of asteroid strike. They have also, survived the climate change, and they have also survived the COVID associated, the pandemic associated scenarios, what we got. And if you look at the incidence of fungal infections, 300 million people are affected by serious fungal infections. And the death due to fungal infections is comparable to that of tuberculosis. And the most common fungal infection, if you look at it, is candidiasis. Whether if you look at its superficial, you have oral thrush or vulvovaginal candidiasis, or in the deep fungal infection, you have candidemia. And if you look at the cumulative incidence, the incidence of fungal infection is very, very high. And this is attributable to the increase in the incidence of HIV, increase in medical and surgical interventions, ICU patient, transplant patient, increasing use of immunosuppressive agents, then climate change, then of course the pandemics also. And as a result of this, WHO has released fungal priority pathogen list, in which there are so many species of Candida, like Candida auris, which is an emerging species. Then you have Candida albicans and Candida tropicalis, Candida parapsilosis, so many of them. But they are definite, apart from the common factors which are responsible for the increase in fungal infections. If you could see, there is definite challenges in India, like overcapacity patient load and healthcare facility, whether you visit the government sector or the private sector. And there is compromise in healthcare, and India is the capital of diabetes. 2 years back, we used to call it second capital of diabetes. Now it is the capital of diabetes. How many times we are not cleaning our spore count is high. The compliance to therapy is also very, very poor. There is a tropical climate. Then, of course, the hand-me-down prescriptions, and then over-the-counter availability of drugs, antifungals also. And then there is, lack of dedicated mycology laboratories. And the awareness is also less. There is no national program, and therefore, hence the availability of free antifungals is also there as not there, as there is no national program. So because of all this, there is a spectrum change. There is emergence of new species, Candida auris, which is again attributable to certain local factors. And then, of course, it's a climate change pathogen also. And then rare yeast causing outbreaks. I will be restricting my talk to the yeast itself. And then there is emergence of azole resistance in Candida. Then echinocandin resistance is also emerging. So it is the predominant cause of fungal infection, Candida species in healthcare facilities, causing morbidity and mortality. Both invasive and non-invasive form of infections are there in the diverse patient population. So you not only have the immunocompromised patients or the ICU patient, wherein we see invasive candidiasis and candidemia, but also we have immunocompetent individuals, wherein we see mucocutaneous candidiasis. And Candida species, in some studies, they are the third most common cause of bloodstream infection in some Indian studies, and otherwise worldwide, it is the fourth most common cause of bloodstream infection, causing serious HAIs. In India, the incidence is 6.5 to 6.8 cases per 1,000 admission. In USA, it is 25,000 cases per year. The true incidence is higher because there is poor sensitivity in the blood culture, because in cases of abdominal candidiasis or the deep-seated candidiasis, the organism is multiplying in the internal organs. So you may not get a blood culture positive. And as a result of which, there are increased number of patients which are difficult to treat Candida infections. There are new underlying host factors like, the pandemics were there, COVID associated or transplant associated, and there is antifungal resistance causing increase in the, healthcare burden, economic burden, and mortality. And there is emergence of Candida auris. And if you look at the latest nomenclature, it is Candidozyma auris. Multi-drug resistant yeasts are there. Healthcare associated yeast are there. Then there is emergence of fluconazole resistant Candida parapsilosis. Then there is emergence of non-Candida, non-Cryptococcus yeast, which is a global health threat in the healthcare facility. And they have environment which facilitate the transmission also. And of course, then we also have a burden of intrinsically resistant yeast species like amphotericin B resistant Candida lucitianae, then non-Candida, non-Cryptococcus yeast like trichosporon. Then we have fluconazole resistant species like Candida glabrata, Candida auris, so many of them. Then we have echinocandin resistance also, especially in trichosporons, ashae, and Cryptococcus species. So as a result of which, the treatment is complicated. There is decreased susceptibility to the conventional antifungal therapy. And to add to this burden, there are taxonomically unresolved polyphyletic group of distantly related species, and therefore the nomenclature is also changing, as a result of which the clinicians, especially, they say, is this a Candida species? No, the treatment guidelines say that. So they have been taxonomically reclassified also. And the attributable mortality for invasive candidiasis is significant. If you look at, the worldwide, the 6-week mortality rate is 22% in severely immunocompromised patients. In India, it is close to 23%. This all involves the increase in burden of healthcare. The limitations are definitely there. There are the current diagnostic test. Then there is emergence of resistant species in the healthcare associated yeast infections, increase in the incidence, increase in the mortality, and then of course, robust uniform availability of robust mycology lab, that is also to be seen. And so therefore, the prevention of these Candida infections, especially the healthcare associated ones, becomes important. If you look at the largest study and most widespread study, which was conducted in 27 ICU across India in the north, south, east, west, and central zones, you will find the prevalence was 6.5. That was from the PGI Chandigarh. The center was also part of this study. And then early infection was seen. Patients had lower score. Azole resistance was 11.8%. This study was published in 2015, but it was planned in 2010 and 11. And if you look at the species distribution around, 13 to 14 years back only, you were able to see 31 species, and the prevalence of Candida auris, which is a multi-drug resistant yeast, to be 5%. Candida tropicalis, of course, was the most common pathogen and still also. And then high mortality was seen. There was a vast spectrum also. And so that was the Indian scenario. What about the global scenario? Since the healthcare practices are similar in Southeast Asian countries, so we have more of Candida tropicalis, like especially which is transmitted from hands of healthcare workers, and similar data you see in Indian subcontinent and the other Southeast Asian country like Thailand, Myanmar, Malaysia. You see more of Candida tropicalis. But if you look at the Nordic countries where the population is also not so high and the infection control practices are also stringent because the load on the healthcare facility is less, the population density is less, there is more azole susceptible species, that is Candida albicans. And if you look at the scenario now, so that was a study which was conducted 13 years back, but published 10 years back. If you look at the scenario, at that time, Candida auris was 5%. But now if you look at, this is the Gangaram study, which says that the Candida auris is close to it is close to 40%. And if you look at the Maharashtra study that is from Pune, Candida auris is close to 43%. And even during pandemic also, the study from Rajasthan, Jaipur especially, it showed that there was twofold rise in incidence of candidemia, and Candida auris incidence was 42%. And most of these strains are clade 1, which are showing resistance. And these Candida auris strains, they are resistant to 97% of the time to fluconazole, 54% to voriconazole, 30% to amphotericin B. So you can imagine the impact. And if you look at there is emergence of non-albicans Candida. Apart from Candida auris, there is Candida blanchi, Candida krusei, Candida lipolytica. And then if you look at the global scenario, there is again one multi-drug resistant yeast, that is Rhodosporidiobolus fluvialis, which is emerging yeast in China, which is causing fungemia, which is a multi-drug resistant yeast, and it develops resistance very fast. It has temperature mutants too, and it is resistant to azole and echinocandins like Candida auris. So this is a cause of concern. What is happening in China? It will definitely affect the world later, whether it is the viruses or the yeast. And then, of course, there is non-Candida yeast like Trichosporon, Pichia, Saccharomyces, which are emerging. And then, like in the Asian ICU, we see Candida tropicalis. And so still Candida tropicalis is the most common species in India. It causes high mortality, but increasing azole resistance is seen in Asia, including India. Initially, Candida albicans and Candida tropicalis were supposed to be the susceptible species, but now the resistance is also emerging. Then if you look at Candida auris, this is the most common species in critically ill patients, especially the ICU patient, because it has the propensity to be sticking around on the linens, on the hospital bed rails. It is multi-drug resistant. It is resistant to disinfectants also, and it has high mortality, and it is very difficult to identify also, which I will be covering how to identify it. Then there are certain yeasts which are removed from Candida species, like Candida lucitianae is now Clavispora lucitianae. As a microbiologist, we will still remember the names, but for the clinicians, as far as the treatment guidelines, they will again ask, is it Candida species the same? So this is supposed to be an amphotericin B resistant species. Then Candida kafer, again, multi-drug resistance has been reported. Then, the Candida pelliculosa, the new name is Vicromens, that is W. anomalus. So, I mean, it is again, these are transmitted by hands of healthcare workers. So if you look at this, the latest articles from 2024 and 2025, and this is the top right article from Trauma Center of All India Institute of Medical Sciences, Candida species has become the third most common cause of bloodstream infection, and there is emergence and establishment of Candida auris in the healthcare facility, especially in the ICU settings. And So it is developing resistance. It is in fact developed resistance, difficult to eradicate, easily transmitted between hands of healthcare workers, persistently colonization on skin, hospital environment. It causes severe infections and the mortality is close to 50%. It is widespread now globally, seen in more than 50 countries, and mortality is also 50%. And it's difficult to identify, but with the, the automated, the Vitec, newer generation of Vitec, you are able to identify, but still at times the automated system and the conventional you miss. So the Malditov and post-culture sequencing, they are important tool in identification. Then it shows multi-drug resistance. There is no, CLSI breakpoints also, and therefore, when it was first isolated, like 2009, from the ear of a Japanese patient, that was superficial infection, and now it is close to 16 years. It has established itself in 50 countries, and therefore ICMR put it on alert pathogen list in 2017 itself, and it is also CDC alert pathogen also. And if you look at the identification, it is by the sequencing of D1, D2 domain of the 26 ribosomal DNA gene, and increased use of fluconazole and other antifungals as prophylaxis or therapy has increased the incidence of Candida auris. And then apart from Candida auris, there are other multi-drug resistant Candida species that are emerging: Candida glabrata, Candida krusei, Candida lusitianae, and members of Candida Guillemandi complex, Candida Kafer, and Candida himmelii complex. And of course, in this takes the lead is Candida auris. It has 6 clade, and clade 1 is very common in South Asia, including India, and clade 6 is very common in India, that is Indo-Malaysian clade, what do you call? And then Indian strains of Candida auris also show amphotericin B resistance. So this is worrisome. But there are certain hints which I will be covering, how you pick up Candida auris by conventional technique also. And even on Vitec also, you have to supplement 1 or 2 tests so that you can identify it. So there are risk factors: duration of the ICU stay. If it is, median is 25 or worse day, then it is high chances, high priority antifungal exposure. Duration of central line, if it is median is 10 days, then you're likely to have. So any patient with sepsis and wherein invasive management is being done and antifungal therapy has been receiving for long periods, and especially those patients, this is very commonly happening, like patient in the private hospital, after spending 14-15 days in the ICU, they because of the cost factor, they get shifted to the public healthcare facilities for the ICU, and therein they are already exposed in the previous. So whenever these patients are getting shifted, investigate for Candida auris. So when do you suspect Candida auris? If the patient is from ICU and high dependency unit, if the patient is transferred from another hospital with history of long-term stay and long-term exposure to antifungals, history of instrumentation, foreign device, and then if the organism appears to be resistant to fluconazole and shows high MICs to voriconazole, and there are certain hints like it grows at 42 degrees, it is able to survive salt 10% or cyclohexamide tolerance also, then these are all important hints. So if you're getting budding yeast cells on corn meal agar, or your Vitec is showing certain pathogen like Candida himmelii, subject it for like heat test, cyclohexamide, and salt tolerance. And if it is positive and all, give it as Candida auris. And so it is identified, by the commercial system as Candida himmelii. Even the 3rd generation sometimes is not able to pick. So it is misidentified as Candida himmelii, Candida femata, Candida lusitianae, and Rhodotorora glutinous, and Saccharomyces cerevisiae. But I have just given you certain hints. So for accurate species level identification, sequencing dependent DNA methods, ITS, and D1, D2 domain of 20S ribosomal DNA. And then there are certain, sequencing independent DNA methods like PCR. You have Candida auris specific primers, real-time PCR is there, LAMP is there, then T2 magnetic resonance is there, which picks it up. And then for typing, especially in outbreak scenario, you can do whole genome sequencing or MLST. So, and of course, then you have certain culture dependent tests also, like you have a special chrome agar for like Candida, that is chrome agar plus, which picks up Candida auris. Then you have certain PCRs also, which pick up Candida auris. And so there are a whole lot of misidentification by the various automated systems, which I have enlisted. So along, if you're having budding yeast cell on corn meal agar and your the automated system is showing these species, please put up the heat test, salt tolerance, and cyclohexamide tolerance also. So you cannot identify by field, but I have given you certain hints. It shows antifungal resistance, 80% to fluconazole, then voriconazole, and Pauline is also resistant. Pauline, that is amphotericin B. And there is persistent colonization of Candida auris by multiple body sites of patients, carriage by healthcare workers. It persists in the environment, leading to high transmissibility and protected outbreaks. So how do you, prevent? Most of the time, the source is not known. So on admission of, of the patient, especially screening for yeast carriage, especially from one ICU getting shifted to another ICU, CDC recommends single room. So possibly we may not cohort the single patient, but yes, if 3-4 patients have got Candida infection or colonization, then we can cohort them in one particular room with dedicated nursing, contact precaution, hand hygiene, and maximum sterile barriers upon insertion and use of chlorhexidine for skin disinfection, skin decontamination, then with and oral gargles with chlorhexidine containing compounds, then environmental cleaning, chlorine and hydrogen peroxide product in patient environment, which I will be covering in my IPC practices, then surveillance for new cases to detect ongoing transmission. Then there is one thing known as targeted screening for prevention and for response on admission, especially the I1 from one ICU, the patient getting shifted to the other, and in the transfer or discharge, contact precautions, and between transfer of cases, interfacility communication about the Candida auris status is also very, very important. So this is a study from PGI Chandigarh, wherein they have found out that this alcohol, that is 70% alcohol, shows a good, like for hand wash, then alcohol plus chlorhexidine also shows good for hand wash. So then how to collect sample and method to detect? Of course, you have the Candida plus chrome agar, where the Candida auris shows this typical color. These two colors they have shown. And so CDC recommends using a composite swab of the patient bilateral axilla, armpit, and groin, then salt or dulcitol enrichment broth, and 10% salt inhibits the growth of most, but not all these species. Candida auris will grow. Candida glabrata, can also grow in high salt, but then again, if you add dulcitol, then Candida glabrata cannot assimilate dulcitol. And then again, for confirmation, of course, you can have MALDI-TOF and sequencing, and there is a real-time PCR kit also. Now, what about the antifungal resistance of the various species? One is clinical resistance, which I have shown you, which I will cover, like persistence or progression of infection despite the appropriate therapy. And then the other thing is microbiological resistance, that is non-susceptibility of a fungus to an antifungal agent by in vitro susceptibility testing. And multi-drug resistant in fungus is resistance to at least one agent in 2 drug classes. So we have azoles, we have echinocandins, we have polyenes, and so at least 2 drug classes, so one each. And then XDR is resistance to at least one agent in each of the 3 drug classes. So then, of course, there are other factors also, like the host immunosuppression, then treatment of the underlying control of the underlying condition like diabetes, poor adherence to long-term antifungals, and antifungal resistance, especially intrinsic or acquired, then that leads to clinical failure. So now, what is the mechanism? Like resistance to azole, it can be through multiple mechanism, like through mutation or overexpression of azole, like target, that is ERG11, and or CYP51A, and that is for ERG11 is for Candida albicans and Cryptococcus neoformans. And then, of course, you also have the efflux pumps also, and then that is pump overexpression, and then you also have the cellular stress response. And if you look at the echinocandins resistance, that is related to mutations in the FKS1, which encodes this glucan unit, which are most prevalent mechanism of echinocandin resistance. Then, so if you look at this Candida tropicalis in this study of PGI Chandigarh, it was like ranging from in the study, it was like from 5 to 41% that is susceptible. And this is the bar diagram showing susceptible, dose resist, dependent, and resistant. And so these are the various MIC ranges in the study. And this is the azole resistance as far as the world scenario is concerned. And if you compare it with India, you will realize that in India, the overall antifungal resistance is close to 80% fluconazole, 21% voriconazole, 35% choline, and 4 to 19% echinocandins. And the resistance in other countries, if you look at USA, the predominant organism is Candida albicans. There it is, it is close to the fluconazole resistance is 2%. For tropicalis, 5%. For Candida parapsilosis, it is 4%. And then they have Candida glabrata also, which shows around 10% resistant to fluconazole. Now, this is the echinocandin susceptibility profile, wherein they found out that the echinocandin, they were resistant in 5 to 10% of the cases. This was during that study. And if you look at the world scenario, like in India, it is, like 5 to 10%, so 9.5% caspofungin resistance in Candida auris. And whereas if you look at the world, it was, there are various, for example, USA, the echinocandin resistance is less than 1%. So again, here, the scenario is quite high. And then this is again the drug-resistant menace in the other Asian countries as far as the Candida auris is concerned. Here, India and the Southeast Asian countries are similar. And then there are multiple outbreaks caused by these rare species like the Pichia anomala, Codemia umeri, Candida vishwanathi. And they are supposed to be, especially Candida vishwanathi, azole resistant, Pichia fabiana, Trichosporon, Malassezia, and then Rhodosporobolus fluvialis. This is emerging in China. So these are the various outbreaks. The source could not be enlisted, but these, especially Candida vishwanathi, they have high MICs for fluconazole. And this is Saccharomyces fungemia. So again, this was also reported related to the use of probiotics outbreaks. So even the ECMID and the ECMM joint guidelines say that there is emergence of non-Candida, non-Cryptococcus yeast like Trichosporon geotrichum. In the Shiham Candidemia network study, the incidence was less than 5%, but now it is high. But the worrisome point is all except Codemia and Saccharomyces, all other yeast which are non-Candida, non-Cryptococcus, they are intrinsically resistant to echinocandin. So this is a matter of concern. So challenges in India, rare Candida and yeast outbreaks are there. The epidemiology is not known. Lab diagnosis is a challenge. Specific identification requires expertise. Antifungal susceptibility, there are no breakpoints, CLSI breakpoints, and therefore take help of the reference lab after performing all these tests where the sequencing or the Maldito facilities are available. And but at least give susceptibility to the clinician, and so that by the time your result comes, which species has caused the outbreak, at least the patient is treated and the source of the outbreak is investigated. Yeah. So if you look at candidemia, there are certain like proven case, probable case, or the possible case. Proven case means like microscopic analysis, it will be there on tissue biopsy, and culture will be from sterile material like blood, CSF, or you can also have, freshly placed drain in cases of abdominal candidiasis, less than 24 hours drain. Then blood culture will show yeast or yeast-like, it could be Candida or it could be non-Candida, non-Cryptococcus yeast also. You can also do serological analysis like you have the Candida mannan antigen, but cryptococcal antigen is most, for Cryptococcus species, like very highly sensitive and specific. And then like the freshly frozen tissue is there. So there, if fungal yeast or DNA is identified by PCR, followed by sequencing, this is all proven then. So this is the EORTC guidelines. So recovery of a yeast by culture of a sample obtained by a sterile procedure, that is blood culture, or less than 24 hours drain from a normally sterile site. So you will have, in tissue or cells along with that, you will have the yeast, or if it is trichosporon, then you can have pseudohyphae and hyphae also in trichosporon, geotrichum, and blastocysomyces. So clinical suspicion of candidemia: fever with signs and symptoms of sepsis, with or without focal signs. Blood culture will show growth of yeast or yeast-like organism. And of course, patient with risk factors, not responding to antimicrobials and antibiotics, and deterioration in the underlying condition. Radiology, the ultrasound showing target lesions in liver and spleen. On fundus examination, fluffy shadows are there. So now what are the various other deep-seated fungal infection? You have primary peritonitis, you have secondary peritonitis, and then you have intra-abdominal abscess and secondary peritonitis stemming from hepatobiliary or pancreatic source. You have intra-abdominal abscess, you have infected pancreatic necrosis, you have cholecystitis, all related to candidiasis. So intra-abdominal candidiasis. Here, again, I would reiterate, you can have mixed bacterial and fungal infections. And if you can get, the biopsy, like that would be the best sample in these cases. And if it is basically, you can also have, it is same principle. The treatment is based on the same principle as that for candidemia. And Candida peritonitis, infection is suspected when the organism is cultured from samples obtained intraoperatively directly from an intra-abdominal collection. 2 points are there. So intra-abdominal collection means during intra-operative only. And again, the guidelines, treatment guidelines are, the echinocandins are the drug of choice. Then biliary candidiasis, again, ERCP will be very typical. And you will have, again, for the sample, again, you will have from the drain site, which is less than 24 hours placed drain tube. And pancreatic candidiasis, sample for cultures, pancreatic or peripancreatic necrotic tissue, abscess and pseudocyst obtained at operation can also be a sample. And endoscopically necrostectomy obtained tissue, that can also be, an CT guided aspiration also. And and these are the guidelines which I was mentioning, which have been released in February 2025. Global guidelines for the diagnosis and management of candidiasis, which is an initiative of ECMM in cooperation with IAMM and ISM. So suspected invasive candidiasis, clinical presentation non-specific, non-responsive to broad spectrum antimicrobials with or without focal signs of infection. So you need to have the detailed patient history, including host factors, risk factors, thorough physical examination with focus on potentially affected organs and vital signs. And this is the site of infection. Then imaging procedures in case of suspected organ manifestation. So candidemia, you can have fundoscopy, that is a non-invasive, by an ophthalmology SR. The ICU SR or ICU clinician sends a call to the ophthalmology SR for fundus examination. Fluffy shadows will be there. For deep-seated invasive candidiasis, abdominal ultrasound is there. And then again for the deep-seated invasive candidiasis, again, abdominal CT, deep-seated invasive candidiasis. If it is nervous system involvement, then brain MRI. So apart from the usual, blood cultures, the other radiology also plays important role. And so then there is a specific indication for echocardiography also. And then the diagnostic yield of blood culture is also very, very important. And to increase the diagnostic yield, they always say, like, for example, if blood culture is also sent and urine culture, that is a non-sterile site culture, is also sent. So that is a colonization site. But if you see on direct microscopy of urine and you're getting in growth also, you're getting urine. Urine is also showing growth of Candida species. Along with that, blood culture is positive. So you can think of candidemia. But if blood culture is negative and you're getting the wet mount, you're getting budding yeast cell, pseudohyphae. On culture also you're getting, then you will just ask the clinician or the intensivist to change the catheter. Then with the change in catheter also, again, if you're getting in the urine sample, in the direct microscopy also and culture also you're getting, and then you will ask for the ultrasound of the patient. If the bladder wall is showing thickening, or if there is a resistant yeast and there is focal lesions also on like cystitis, or you have target lesions and there fundus is also showing fluffy shadows, then that is the indication for antifungal therapy. Otherwise, like if you're getting on first isolation, you just have to advise for the change in urinary catheter. And then, of course, for candidemia, 40 to 60 ml of blood across 2 to 3 blood culture sets incubated for up to 5 days. And even after 5 days, if the automated system has not beeped, please subculture it and again incubate the plate for 48 hours, because at that time, the culture is showing the growth of Candida species, that is after 48 hours. And then again, deep-seated invasive candidiasis, sampling from focus, sterile site culture, aspirate, biopsy, and drainage. And again, if you are having sample other than blood, direct gram stain or any positive fluid staining followed by culture is equally important. Then, of course, species identification is very, very important, because there are certain species which are resistant to azoles. So, and then susceptibility testing is very, very important in these sterile site samples. Then identification, of course, you have the chromogenic agars also. You have the conventional technique, you have Vitek identification, but these all can give misleading results. So you have the other confirmation is by Malditoff MS and by PCR. Then you have fish, that is fluorescent in situ hybridization probes also, which are available. But don't miss on the susceptibility testing. So identification of Candida to the species level is strongly recommended. So then what about the biomarkers? You have for candidemia, the deep-seated invasive candidiasis, or the candidemia, you have serum beta D, glucan level, multiple beta DG results improve the diagnostic certainty. And then deep-seated invasive candidiasis, Candida mannan combined with anti-mannan antibodies. Then for CNS candidiasis, CSF beta D glucan testing is also recommended. And so these are the various recommendations which I have just mentioned, but do not delay the sensitivity. Give the sensitivity report to the clinician. Maybe you're identifying it as non-albicans Candida. Don't wait for the Malditoff or sequencing result and then initiate the antifungal therapy. Give it as non-albicans Candida or a yeast or whatever identification you have done with the AFST, and do the maximum speciation. So diagnosis, you get a direct microscopy, and then blood culture 50% of the time they will miss because they are multiplying in the internal organs. So these are the various, conventional methods, the chromogenic agar, or that is, chromagar, or then you have the carbon and nitrogen assimilation. Even your automated Vitek systems, those automatic methods of identification, they are also doing assimilation of the biochemical markers only, and then MALDI-TOF and PCR sequencing for identification. If you delay the diagnosis of candidiasis, there is 15.4% rise in the mortality. So you need to decrease the turnaround time. Microscopy is affected by the man-made subjective factors. Culture is time consuming. Histopathology, we are not doing, especially it's an invasive specimen collection. So in critically ill patients, we are not able to do. CT scan will have low specificity. So many, target lesions will be similar. So therefore, there is a reliability on fungal biomarkers, which could be nucleic acid based and non-nucleic acid based. If you look at Candida, you have mannan and anti-mannan antibodies, beta-D-glucan. Then you have the T2 Candida nano-diagnostic panel. Also for Cryptococcus, you have the capsular antigen. And then for all the fungal infection except Cryptococcus and Eukaryotes and Blasto, we have beta-D-glucan as a pan-fungal marker. And so these are important point of care tests which are available. And so thanks to them and a combined blood culture, you can give the report as early as, within 24 hours. So antifungal therapy, if you've given empirically negativity of two markers, withdraw the treatment. So they have important negative predictive value. Beta-D-glucan, of course, it is, it has its own limitations, false positive, false negative. And then there is a platform that is Fungitel platform where, again, you can have the batch of 1 to 7 samples instead of 17. You have clear platform, which is available, but decreases the contamination. And the combination of biomarkers is the need of time. And beta-D-glucan with mannan antigen has better performance in candidemia diagnosis. And again, for chronic disseminated or candidemia, mannan with beta-D-glucan is recommended. So there are other recent advancements also which are available, like which I will be covering. And if you look at the molecular methods, you have yeast traffic light, you have BioFire, that is the automated rapid multiplex real-time PCR, which has various panels, or the blood culture BCID panel, or the septicemia panel, or the arthritis panel, or so many panels are there. And then you have T2 Candida and molecular methods. Of course, the real-time PCR is more specific as compared to other. There are so many PCR platforms which are available, decreasing the turnaround time. And though EORTC criteria recommends only 2 PCR, that is, one is for Aspergillus PCR and Pneumocystis PCR, and it also recommends T2 Candida panel, but all in the probable category of fungal infection. This is automated multiplex real-time PCR with a syndromic approach in which the yeast enlisted are Candida albicans, Candida auris, Candida glabrata, Candida krusei, Candida parapsilosis, tropicalis, and Cryptococcus neoformans. And then you, of course, have these 5 species you can identify by the yeast traffic light PNA fish. And then loop-mediated isothermal amplification is also available for Cryptococcus Candida species, Saccharomyces and Trichosporon. Then for rapid test, if you want to decrease the turnaround time, again, this is T2 Candida can detect 6 Candida species, including Candida auris, and detection sensitivity of 1 CFU per ml. And so then you have surface enhanced resonance Raman spectroscopy also, which is the recent technique. Then, of course, apart from the identification of yeast and mold, you can do typing using MALDI-TOF, antimicrobial susceptibility, especially for Candida species 5. You can then direct testing of the clinical samples also you could do. Then what is the role of sequencing in pathogen or the yeast identification, in the drug resistant detection, in the outbreak investigation, and for, like if you want to do any comparative study, and the whole focus should be on to decrease the turnaround time. So a combination of biomarker, conventional method, or this should be. And what do the antifungal stewardship people say about candidemia? High volume blood culture to be repeated at least every other day until clearance. So do your basic test right, and every other day. Then central venous catheter chain, beta-D-glucan, serial serum, monitoring needs to be done. And if the patient is on voriconazole, then therapeutic drug monitoring is also recommended. So, but if you look at antifungal stewardship, first make the diagnostic robust. First you need to diagnose and then talk of antifungal stewardship. Very important to differentiate between albicans and non-albicans, Candida. So there's a panel, like if you have yeast, black yeast, that is different. If you have yeast which are moist mycelium, then non-cryptococcus, Candida species. If you have pink to red, you can have sporobolomyces. So these are the various chrome agars which are available, which you could help in detecting your. If you look at Candida auris, have it sparsely produces pseudohyphae. It's normally a budding yeast cell on corneal agar. It could be deep purple or light pink or white in color, but have these three tests: salt tolerant, cyclohexamide, and salt tolerant cyclohexamide with Candida auris and with heat test. These are the various types, and even rare species also you can identify. Then Epidemiology omeri, again, it's luckily, thankfully, it's a susceptible yeast. Then Saccharomyces cerevisiae outbreaks have also been reported. Trichosporon, you can identify the colony. It is again a resistant yeast, especially to amphotericin B and echinocandin. Geotrichum, the drug of choice is amphotericin B and voriconazole. There are other emergence of Magnesiomyces capitatus, that is Geotrichum capitatum. And again, this causes infection in transplant patients. Then pseudozymite appears like that of, it's an ASB, but actually it's a yeast. And again, this is supposed to be a resistant yeast. Then Rhodotorola, again, the drug of choice is amphotericin B, and sporobolomyces. It is an intrinsically resistant yeast. Then other yeast for malassezia, it's very important. It can cause infections, disseminated. Usually it's a superficial fungal infection, but it can cause deep-seated infection, especially patients who are on CVC and TPN, because it's a lipophilic fungus. So if you're getting this on gram stain, a typical bottle appearance, and when you're doing subculture, please do a sterile over olive oil overlay, and then you'll get a luxuriant growth of Malassezia species. And you can identify by other methods, but if it's growing on that, the new guideline says that for Malassezia species, you keep the blood culture bottle for 14 days, the new guidelines which have just released in February. And then Cryptococcus, thankfully, it can be picked up on India Ink, and culture is also, it is easy to grow. And then cryptococcal lateral flow assays also is quite sensitive. Now, what do the clinical practice guidelines, IDSA guidelines, say? Echinocandin. What do these guidelines fall short of? They do not have any mention of Candida auris and the newer antifungals like Reza fungal, because these were released in 2016. But otherwise, they also mentioned that echinocandins are the drug of choice, and follow-up blood culture should be performed every day or every other day. But the recent guidelines which have come up, every other day is good enough. So current treatment recommendation, it says caspofungin echinocandin, that is. So, but is it readily available? So the need of the hour is tailoring the treatment, the international guidelines, to the local resources which are available. So these are the global guidelines for candidiasis, which is an initiative. The echinocandins are the first line. Daily follow-up of blood cultures until you have 3 consecutive negative days. And if blood from day 5 is positive, repeat search for intravascular or other uncontrolled source. So this is, the previous one was saying 14 days until the last blood culture, which is positive. So daily follow-up blood cultures until 3 consecutive negative days is there. And then liposomal amphotericin B is the first line. They have recommended, especially in cases of CNS candidiasis, because echinocandins cannot enter CNS or the eye infections. Infection prevention control, it's an important measure in Candida auris or the yeast which are resistant. And then enhance IPC measures, Candida auris, fluconazole resistant Candida parapsilosis. Then genetic typing methods are also need of the hour for the outbreak investigation, especially whole genome sequencing. And then if you look at these infection control strategies, screening of close contacts of the index patient on the same ward and those transferred from facilities outside to your hospital is also very, very important. And then what about the infection control recommendation apart from the hand hygiene or the carriage, colonization and all that? They say that you need to, for sodium hypochlorite as terminal cleaning or hydrogen peroxide as terminal cleaning agent is recommended. And so these are the various agents. But if you look at quaternary ammonium compound, the recommendation is D. It means it is not recommended. And then if you summarize, there is rise in incidence of invasive candidiasis, that is candidemia, increased morbidity and mortality in critically ill patients. Then they need to be a surveillance for the new entities and the new species like Candida auris or the COVID-associated candidiasis or COVID-associated cryptococcosis. These are the novel entities. And for novel species, if you're getting an unusual species, take help of the reference lab. After you've given the susceptibility to the clinician, after doing the initial identification, take help of the reference lab. You have a WHO recognized lab at PGI Chandigarh, and then of course the DBT one is at Patel Chest. Then of course there are 8 ICMR centers also, which are spread across the country zone-wise. Then newer non-culture based methods are available, but they have an important, these biomarkers have an important negative predictive value, role for prognosticating, for monitoring the duration of therapy. Of course, they have certain diagnostic limitations also. The best approach would be combination of methods or the array of tools. The gold standard of culture is here to stay, because otherwise from where you will put up the antifungal susceptibility. Follow the infection prevention control care bundles, and then special scenario require the escalation of the IPC practices with multi-pronged and multidisciplinary approach. And to curb the overprescribing of antifungals, you adhere to the principle of antifungal stewardship. And then antifungal resistance is definitely emerging, has emerged in Candida auris, non-Candida, non-Cryptococcus yeast. And it is a challenge for identification. There are no CLSI breakpoints also, but we take certain cues. We see the epidemiological cutoffs. Then challenges, of course, these rare species outbreaks require multi-pronged approach, and we need to develop the local diagnostic algorithms for invasive candidiasis. Follow the guidelines whenever in doubt, but it's high time that we need to be adapting these guidelines to the local context, your local hospital antifungal data, and local, as per the treatments or the therapies which are available. So here I would end my slide with this, the culture is here to stay. It is not that these marker and these biomarkers, whether it's the biochemical biomarkers or the nucleic acid based biomarkers are here. We have to take help of the combination of methods or array of tools to decrease the turnaround time for Candida species. Thank you.
All right. Thank you, Dr. Malini. That was really very comprehensive yet exhaustive. And I'm sure a lot of doubts of PGs have been cleared. So there are a few questions, Malini, for you. First is how to interpret antifungal susceptibility of Candida auris in Vitek 2.
Yeah, because that is an enigma, I would say, especially Vitek 2, because even the echinocandins will give, haywire results. So if you look at amphotericin B, if you have an e-test of amphotericin B, because gold standard is broth microdilution, but broth microdilution being cumbersome in a single, technician lab or a limited resource lab, you're not able to do broth microdilution. So as far as e-test is concerned, you can have amphotericin B, you can also have caspofungin, that is for routine diagnostic, you can give the report. And then, of course, the IPC bundles are there. Then the screening for the colonization sites are also very important. And you have to look out for other patients also, whether the other patients also have like Candida auris or not in that particular ICU. There is
Okay.
epidemiological cutoffs which are available, which I can share for Candida auris. Yeah. Okay. Then,
Yes, another one is that this happens many times that there is an isolation of candida from blood culture of a patient, and when you follow the case, you realize that there are no symptoms and the patient has become all right even without, say, antifungals. So, when can we say that the isolation of candida in blood is significant, or is every case significant? And are there any guidelines to call it that it is colonization versus candida? These are
yeah,
two, three questions which I have
yeah,
combined.
yes, yeah. First of all, like you need to have the isolation from a sterile site or a freshly placed drain. That is very important. In the setting of sepsis, that is important. And especially if the patient is not responding to the broad spectrum antibiotics. But if you have a patient like in the ward who is ready to get discharged, there is no worsening of signs and symptom or worsening of the underlying condition, then of course that is just a skin contaminant, I would say. But if you have a patient in the setting of sepsis, worsening of scenario, and if you can take help of these non-invasive method, if the patient's fundus is clear or the patient's ultrasound, there are no target lesions, that also can give you a cue. Yes, that is a colonizer. I mean, that is come from skin. So that is, yeah.
Like we say always, please treat the patient and not the report.
When you're collecting the sample, because this happens when a new set of JRs or new set of interns they join, and then we note, and then we so it has to be in the clinical setting. But any isolation of candida, especially from blood, in case of ICU, should be treated. I mean, seriously. But if your patient is like from ICU is being shifted to the ward, then still track that patient. I mean, because you never know, because that patient again from ward might again have deterioration of signs and symptom and get back to ICU. So it is not that if you've got an ICU patient and you've isolated on blood culture and the patient is ready to shift to ward, but if there is deterioration, think of this report that yes, it was blood culture positive.
Okay, so do you recommend that the blood culture should be repeated after few days of therapy in candidemia?
See, if you have, yes, see, IDSA guidelines say like if your blood culture is negative, then 14 days from that. And here again, these guidelines, they say that you have to repeat the blood cultures. If you look at the table which I had shown, it says that, like after collecting that particular volume of blood culture, you need to have those follow-up blood cultures until 3 consecutive negative days are there. And if blood from day 5 is positive, repeat search for intravascular or other source. This is what they say.
All right. Another one is that because Candida auris cannot be reliably identified by Vitek 2,
Yes.
then can you perform AFST using this system? How will that be possible? Because you will not have the the breakpoints to interpret in the machine.
Yeah.
So,
So my suggestion would be like, even if you're getting like Candida humulini or Candida formata on or Saccharomyces on Vitek, it is high chances that it could be combine it with other methods, like you have uh, salt tolerance or heat test is readily available that you can do, because that at 42 degree, if that yeast is growing, so that is Candida auris, you can perform. If your lab has got 3-4 technicians, then of course you can do broth microdilution, which is a gold standard. But if you have e-test available, give the clinician at least something, like for amphotericin B and for echinocandins, caspofungin is their e-test is available. So you can give that. And if that particular strain is showing azole resistance, it is likely to be Candida auris in presence of these two test positive, heat test positive and salt test positive.
okay. Actually, what Priyanka is trying to ask is that if you have a Candida auris, like in our lab we have MALDI which identifies Candida auris,
Yeah,
and
yeah,
then in Vitek, because there are no breakpoints for Candida auris, which
yeah.
organism you assign to when you are putting the Vitek for AFST? Because if you put it for Candida
Candida cruzi.
albicans, so
Yeah.
can it be
Candida
Candida
cruzi.
albicans
Yeah.
which can be put up?
Yeah, it can be this thing for Candida cruzi, because it is supposed to be a
Okay.
resistant yeast. And then there are epidemiological cutoffs also, which are available, which I can share, to you, and you can give it to the participants for Candida auris. There are certain epidemiological cutoffs are also available. So
Okay.
that can be taken care of. Yeah.
And somebody wants to understand the concept of MIC 90, MIC 50.
MIC 90 is where 90% of the isolates are, inhibited. And MIC 50 is when 50%, if you've taken 100, 50% of the isolates are inhibited. So for Candida auris, the MIC 90 is also very high. So it's that, yeah.
Yeah. So the basic concept here is that you put up a cumulative frequency. You
Yeah.
arrange your isolates in terms of increasing MICs, and
Yes.
wherever you get your 90th isolate or wherever you get your 50th isolate, that is your MIC 90,
Yeah,
MIC
exactly. Where
50.
you're 90%, like 100
Yeah.
liya to 90th isolate, yeah.
Yeah. Uh, is there any where can people get the ECMM ISHAM Candida guidelines,
They're
Malini? That's the
easily
last
available
question.
on Google. They have been released this
Okay.
February only. I will be sharing with you these global guidelines for diagnosis and they are over and above those IDSA guidelines, because IDSA guidelines do not have any mention of Candida auris. Then it doesn't have the newer antifungals also. And then it doesn't mention that amphotericin B should be given, when it can be given. But in these, the newer antifungals are also mentioned, Candida auris, then the latest nomenclature also, the non-Candida, non-Cryptococcus yeast also, and the latest antifungal. I'll be sharing with you these two documents. You could share with the participants.
Actually, we don't register the participants, but what I will do is probably I will, if somebody wants to know, we can
Yeah,
we can
I'll
share
try to
it.
share from
Ha.
my this side. I'll just try from my WhatsApp if I could
No, you
just
share
wait.
it with me, Malini. I will.
Yeah, I'll just share
Whosoever
it with
wants
you
it can
right
ping
away.
me, and
Yeah, sure. I
I
will
can give
just
it to
share
them.
it with you. Yeah.
And another thing is that please don't ask for PPT. The session is available on YouTube. So if you want to go and watch it at your own pace, watch it at your own free time, and you will be able to see everything and learn from everything. If you get a PPT, you will put it on your computer and forget about it. So I don't believe in sharing the PPTs of faculty. So I think
I'm
with that
just
we come to this end. Thank you so much, Malini, for taking out
Yeah,
time.
I'll just share with you on the WhatsApp. Just give
Yeah, sure.
me, wait. Lancet, it's on Lancet February. I'm just sharing so that right away you could share, because it is there on my WhatsApp. Dr. Sonal will be sharing with you these guidelines. Uh, I'm very glad that these guidelines got released, and they are basically taken, 70 societies of Europe and 7 other societies they have taken, and so many experts are there in as author. And I have just shared them with Dr. Sonal, and Dr. Sonal will be sharing right away at the end of the webinar. Yeah.
All right. Thank you, everybody. Let me see if I can put a link on this group itself.
Did you receive it?
Yeah, I got it.
Yeah, great. This is from Lancet, February 2025.
Yeah, so maybe I'll share a link with a DOI or something in the chat box where people
Share
can
this
get it.
PDF only. You can share this PDF. Yeah.
No, how I can't share it, Malini, because we don't keep I don't register these participants, so I don't have their details.
Okay. If we can share in the chat itself.
I don't think we can share a document in the chat.
I'll just try if we could before it.
I have
Before
shared
the.
the DOI number. From there, people can track it. It must be freely available.
Yeah, it is freely available.
So I've shared the link. People
Okay,
can
great. Okay, great.
do it. Yeah. Okay. Thank you
Okay.
once again.
Welcome.
So I'll
Yeah.
log out.
Yeah, one question I could just read. Somebody just type, what are those sites, axilla, groin, earlobe, from where those colonization, is expected. I just read one question in the chat here.
No, there was one question which was asked, what are the sites which you should do for
Yeah,
colonization? That you've already answered.
Yeah, that I've answered. Yeah, just now also. Okay. Thank
I
you.
think we've covered everything.
Yeah.
One more last question. Eagle effect. Is eagle effect common in Candida auris also?
What is common?
Eagle effect.
Yes, it is common. And even that 90-60 rule, you can see those, it's quite common. You'll see, skipping in the MICs, like in the broth microdilution. Yeah.
Okay.
Thank you, everyone. Thank you, Dr. Sonal.
Yes, thank you. I'm trying to share that guidelines itself in the group. That way I will also learn something new.
And I'm glad you took, this month itself before it ended.
No, I can't. It's not possible. Oh, it needs it in certain format. So DOI is there. People can go there and do it. All right, I'll end the meeting now. Thank you, everybody.